our next agenda item today, which is another conversation, another casual conversation. And this afternoon, I'm going to be having the pleasure of having a chat with Robert Newton. So Rob qualified with his PhD, his DPhil in London, with his medical degree in London in 1991, and then went on to Oxford to do a DPhil with the Cancer Research Unit there. And through Rob's DPhil work, he landed up going into East Africa to work on Kaposi sarcoma. And in the many years of his work on cancer, Rob has worked with some famous or infamous names that we know very well, including Valerie Burrell, who was key in doing Kaposi sarcoma work and was also Rob's doctoral supervisor, and Richard Dole, very famously the smoking and cancer, one of the leading names really in cancer research in general. And he worked at the Oxford unit also with Max Parkin, who some of you might know as the one-time head of the descriptive epidemiology program at IOC, and also one of the co-founders of the African Cancer Registry Network. And in 2005, Rob went to take up a position as a lecturer at York University, where he is now a professor in clinical epidemiology. And then in 2012, he was seconded from York to the Uganda Virus Institute through the MRC, and now, which is in Entebbe, for those who don't know, Entebbe, Uganda, obviously. And now he works there as the senior epidemiologist and the head of the cancer epidemiology program at the UVRI. And since his PhD work, Rob has worked in Uganda and East Africa for almost 3 decades, so a very long time. And he's been focused primarily on infectious agents in cancer, and starting with Kaposi sarcoma. So to start with your story, Rob, when you started your doctoral work in East Africa in the early 1990s, it was a time of somewhat political upheaval in the region. We had the Burundi genocide in 93, the Rwanda genocide of 94, and you have told me before a little bit that those were actually cases you'd also started doing some research. So can you maybe tell us a little bit about those first few years trying to do research in East Africa and how you then landed up in Uganda?
Yes, I mean, I finished medical school very clear that I would rather go into population health than individual health. It wasn't that I didn't enjoy clinical practice, I did very much. And in fact, I spent some time in clinical practice and was gradually moving down the infectious diseases route. But I was attracted very much by population health because the impacts it seemed to me that we could have were much greater in population health. When I went to Oxford, I was really undecided about whether to move into infectious diseases epidemiology or cancer epidemiology. And I was completely blessed in the end by the fact that Valerie Burrell at the time was interested in HIV-related cancers, particularly Kaposi sarcoma. And so when I told her of my interest in infectious diseases, she immediately pushed me toward working on HIV-related cancers. And it was a what now would seem very naive hypothesis, but already in 1991, it was clear that the cancers that people with HIV were suffering in excess were cancers that either we knew or at least we thought had underlying infectious causes. So the very simplistic idea was that if I could identify HIV-related cancers, I would be identifying cancers that had an underlying infectious cause, and that was obviously worth knowing. It turned out to be much more complicated than that, but Valerie's initial hypothesis, and I think she was absolutely right in this, was if you're interested in HIV-related cancers, there's really only one part of the world you should be working, and that's in sub-Saharan Africa. That's where the burden of HIV was greatest, and it was also where the burden of many of the HIV-related cancers, such as Kaposi sarcoma, was highest as well, and cervical cancer and many other cancers caused by infections. So in 92, I was packed off to work in Burundi and in Rwanda. Neither went well. In 93, there was a genocide in Burundi, which I had to escape, and then in 94, the same on a much larger scale happened in Rwanda. So by the time I was going to Uganda, I don't think they were that keen to have me because I had such a checkered history initiating genocides everywhere I decided to do a PhD. But we did set up in Uganda, and the project was, I think, remarkably successful. And I continued with a series of case control studies of cancer, trying to characterize the major risk factors for the diseases in an East African setting. And of course, infectious agents turned out to be by far the most important things. So over a period of more than a decade, I was involved in that kind of research, generally hospital or clinic-based. But eventually it reached a stage where we characterized the major risk factors, and it was important to understand what we could do about that. And to my mind, at least, rightly or wrongly, that would involve doing population-based research. And for that, we would need to shift to well-enumerated, well-studied populations. And it turned out that the UK Medical Research Council had a very well-established cohort in southeastern Uganda, which had been set up in 1989, specifically for the study of HIV/AIDS, which at the time we knew very little about. But it was certainly possible to use that cohort, to build on that cohort, to study other risk factors. And my particular focus was on the cancer-causing infections. So for the last 10 to 15 years, I've been doing population-based studies of the major risk factors for cancer in that part of the world. And you can really characterize that with just 4 infections: human papillomavirus, the Kaposi sarcoma virus, Helicobacter pylori, much neglected cause of disease, not just stomach cancer, but also upper GI bleeds, gastric and duodenal ulcers, and hepatitis B virus. And we have programs of activity in all those 4 major infections. It is worth pointing out that when I first started working with this cohort, it seemed important to me to characterize the major causes of death in the cohort. There was a great deal of interest in non-communicable diseases, but of course, we didn't actually have any information on what the major non-communicable diseases were. I think many people forget how huge the data gaps are in sub-Saharan Africa. And outside of South Africa, there is no country in sub-Saharan Africa that routinely collects data on cause-specific mortality. I have no idea what people are dying of. And if you think about it, that's really critical, because understanding the causes of death underpins the whole of public health and public health decision-making. So one of the first things I did was to instigate a system of verbal autopsy, which is not a very robust approach to understanding what the causes of death are. You interview relatives after someone has died about what the signs and symptoms were and what the diagnosis was, if that individual had interacted with a medical practitioner. It's not the most robust, but it's the best we can do. And it's actually turned out to be very revealing. And what it's shown us is that roughly 1 in 5 adult deaths are due to cancer. So it is by far the most important cause of non-communicable disease deaths. And 1 in 5 deaths, 20%. That's really, really significant. And it's more than a third of all non-communicable disease deaths. And yet, when you look at where the flow of funding from the global north is going in sub-Saharan Africa in relation to non-communicable diseases, almost all of it is going toward diabetes research and cardiovascular disease research. So we're working in a very neglected area. And that's been a hallmark of my entire career, actually. It's been a deeply unfashionable area of research where you can achieve a lot. It's not a crowded field. If you're not very imaginative, it doesn't matter in sub-Saharan Africa, because any question you ask is likely to be novel. And that certainly isn't the case in the wealthier countries in the global north. So you can achieve things and you can learn things that people don't already know relatively easily, which is great. It's like me, but pretty unimaginative. So it's been a very exciting and very interesting journey, but it's also been a very difficult journey to fund, and it remains difficult even now. And throughout my career, almost all of my research funding has actually come from the US. None of it has come from the UK, and I think that's very telling. So perhaps it's beholden on people like me and Freddie and others to put cancer perhaps more in the forefront. And he's been doing a very good job at that. Perhaps I've been doing less well. But it is a really critical importance. And I think, as a final comment, if you like, the rather distressing feature about cancer in that part of the world and the causes of cancer in that part of the world is it's not as if we don't know what to do about it. You know, we've got vaccines against cervical cancer and liver cancer. Stomach cancer, Helicobacter pylori, is a treatable bacterial infection if we were to invest a bit of time trying to figure out how best to treat it. Then the next step would be large-scale eradication trials, which have been done in the past but need to be done again. This is a major problem. And as for the Kaposi sarcoma virus, this virus shouldn't be that difficult to develop a vaccine against. No one wants to do it because it's uniquely an African problem, and so there's no money. Nobody's going to pay for such a vaccine. But it is distressing to me how preventable, just with the tools we already have, many of these conditions actually are. And the theme of this workshop, when we're talking about technologies, if you stand back and think about what will make the biggest difference in sub-Saharan Africa, it's not terribly complicated things. We've achieved a huge amount over the years just by provision of clean water and childhood vaccines. I mean, those two factors alone are probably the greatest levelers in terms of global public health of anything. So we don't need to be thinking hugely sophisticated terms, with one or two caveats. There are some areas where some sophisticated technology would be very helpful, particularly in terms of diagnostics and point of care diagnostics, things we can use in the field to diagnose common problems. But simple approaches work. And if you take the example of HIV disease, we're dealing with a virus that is specifically evolved to evade the immune response. So I think we have to start to accept that in the near term, we may never have a vaccine against HIV. But we do have the tools to prevent the epidemic right now in our hands, with antiretrovirals used as pre-exposure prophylaxis and as treatment. The difficulty we've got at the moment is that we don't know how to deliver these prevention and treatment technologies to the highest risk people who most need them, who often tend to be highly mobile and leading quite chaotic lives. So it's a pleasure to be in a room full of social scientists, actually, because I think some of the most important questions in health in sub-Saharan Africa involve social science more than they do quantitative epidemiology at this stage.
I'm sure the social scientists are very happy to hear that. Thank you, Rob, for a very comprehensive and fascinating answer that has a lot in it. So I'll try and sort of pick at some of the pieces you mentioned there. Maybe to go back to the decision originally to go to Rwanda and Burundi, which for very obvious reasons didn't work out. You once mentioned that you ultimately decided to go to Uganda because of people like Henry Wabinga. For those who do not know, was the head pathologist in Mulago Hospital in Kampala for a very long time and very active in cancer research. But Uganda has a long history, especially through Makerere and people like Dennis Burkitt and Michael Hutter, being a center for cancer research. And so I wonder, why didn't you go there in the first place? What was pushing you away from there towards Burundi?
It wasn't that we were pushed away. I mean, collaboration in the end, successful collaboration is all about the people you work with and the contacts you have. We happened to have contacts in Rwanda and Burundi at the time. We were developing contacts in Uganda. And once those contacts were developed, the studies really took off in Uganda. But you're right to draw attention to the fact that Uganda has a long history of extraordinary contribution to cancer research. And I think that's often forgotten. I mean, Dennis Burkitt published his first paper describing this previously unrecognized childhood cancer that now bears his name in 1958. It was a very, very simple paper. And I don't think people realize he was a surgeon, but a meticulous surgeon, and he did describe the age and sex distribution of children with this tumor. And then he thought, well, we don't see this tumor anywhere else in the world apart from Africa. What should I do next? Oh, I should describe the geographic distribution. And this should be a lesson for all of us. He wrote to the Medical Research Council in the UK and asked for a grant of £50 to conduct a postal survey. So he developed a very simple questionnaire for hospitals. You know, do you see this tumour? You have photographs. If so, what proportion of all childhood cancers? And he sent this all over Africa, and was able very crudely to map the distribution of the tumour, and showed that it mapped very closely with the distribution of falciparum malaria. But he didn't feel that was quite enough, so he wrote back to the MRC and asked for a grant of £150 to do a more meticulous survey. And the MRC said, "Don't be stupid, you can't do it for £150. So they gave him £250. And he used it to buy a car, a Ford Anglia car. Now, I don't know if any of you have ever seen the Harry Potter movies, but in the second movie, there's a flying car. That's a Ford Anglia. The real version didn't fly, but he bought the Ford Anglia, and with two friends, he travelled 10,000 miles around sub-Saharan Africa to map Burkitt lymphoma. And they found things that seem relatively simple now, but if you go up in altitude and the mosquitoes disappear, so do Burkitt lymphoma. If you move into drier areas, the mosquitoes disappear, and so do Burkitt lymphoma. And that led to his hypothesis that this cancer was caused by a vector-borne infection of some description. And back in the early 60s, that was a really novel idea that a non-communicable disease could be caused by an infectious agent. And there followed a whole saga of trying to get tissue samples to the UK. He eventually did, and the pathologist Tony Epstein, who when I last checked was still alive, 102 years old, Tony Epstein was working at St Bartholomew's Hospital at the time and had access to one of the first electron microscopes in Britain. And he was able to photograph EBV budding from tumour cells, live tumour cells of Burkitt lymphoma. And that that discovery of a viral cause for a cancer revolutionized the way we think about cancer. It led directly to the cancer program in the US, the hunt for viruses that cause cancer. But it's a tumour that's important in other ways as well, because it turned out to be the first tumour that was successfully treated with combination chemotherapy, combinations of chemotherapy drugs, which led to the award of a Lasker Medal to the Ugandans and one American who were working on it at the time. So I don't think one can underestimate the importance of sub-Saharan Africa in the global oncology world. I think it's often forgotten, but it shouldn't be. One can learn a lot from the differences as much as the similarities of what we find in sub-Saharan Africa compared to the global north.
Yeah, thank you, and that touches perfectly on Noemi's topic on the Hep B work in West Africa, and how David mentioned in our introduction that it's not always north to south that these things happen, but that the south has often actually played very important roles. So you were studying infectious diseases that might cause cancer at the time, which taps a bit into my question on etiology that I put earlier, and research around etiology. And I was wondering, have you seen a shift in the research picture in East Africa in the 30 years you've been working there, in terms of the types of focus for research, the types of support and funding that's coming in, maybe who's doing it?
There certainly has been a shift. When I first started working in sub-Saharan Africa 30 years ago, pretty much all of the research focus, and for very good reason, was on HIV/AIDS. I mean, if you walked onto a ward in a Kampala hospital in 1992, 60% of the people on that ward were dying of AIDS. And that certainly isn't the case anymore. So although HIV, that combination of HIV and TB remains the biggest single cause of death, despite antiretrovirals, it's not the problem it once was. So at that time, really the focus was on HIV, and we were able to slip in a bit of cancer research because we were working on HIV-related cancers. There has been a shift over the last, well, actually it started in around 2010, when the UN had a World Health Assembly. They'd only had one before focusing on AIDS, and this one was focusing on non-communicable diseases. And the report that came out from that was very helpful in some ways, in that it drew attention to the fact that the majority of NCDs in the world were actually occurring in low and middle income countries, not in high income countries. That was a very positive thing because it drew attention to the poorer settings. What was slightly less helpful from the point of view of sub-Saharan Africa is that it focused almost all of the attention on the Western lifestyle risk factors, tobacco, alcohol, obesity, and lack of exercise as being the causes of all non-communicable diseases. And that prejudice still exists very much today. When 10 years ago, I was told that I was an idiot for working in rural Uganda on NCDs. There wouldn't be any. I should just go to Kampala and work on fat people. Fortunately, I refused because 46% of deaths are due to non-communicable diseases in rural Africa. And that's why I hesitate sometimes when I see people talking about NCDs in Africa as somehow being a new thing. They're not. They've always been there. They're just very different. And if one looks at South Africa, you can see what will happen in other parts of Africa over time. We're not doing too much to conquer the infectious diseases, but you have an additional burden of diseases, very evident in South Africa, that are due to Western lifestyle risk factors on top of the existing disease burden. So in South Africa, you've got a lot of cervical cancer due to HPV, but you've also got a lot of lung cancer due to tobacco use and so on. So you get that sort of double burden of disease. And we certainly want to avoid that elsewhere in sub-Saharan Africa. But it would be a shame if we neglected the existing burden of non-communicable disease, because actually a lot of it we can do something about, provided the will is there.
Yeah, I guess the will, the politics, the funding.
I have to say, I didn't start out radicalized. I started out just interested in working in sub-Saharan. I thought the scientific questions were fascinating, but if you spend much time there, the scale of the inequity, I mean, if it doesn't touch you, you shouldn't be working there because it becomes very, very evident after a while. And so I have become more and more radical of it.
All in support of radicalization. You were saying that it's a bit of a neglected area in sub-Saharan Africa, and there's not that much funding. But is that something you've seen change recently? Because as far as we've been monitoring, there seems to have been in the last 5 years or so, amongst quite a lot of governments, a sudden surgence in awareness of cancer, in interest in investing in cancer and opening up cancer units. For example, Tanzania has had a huge push in the last few years to create more cancer centers. Do you feel that it's still very much underfunded or neglected, or has there been a change?
I think where I work in Uganda, it's still very neglected. That isn't to say that there hasn't been massive investment in the cancer center in Uganda. There has. There's been a huge US investment in building a massive cancer center. I've always been a bit hesitant about supporting the push by NGOs when they want to invest in a place in building a building. You build a building, you put your name on it, you take a photograph, you say, that's my legacy, that's what I've done. But there may be nobody in the building who knows how to treat disease. There may be no drugs available in the building. You may have absolutely zero impact on survival from cancer or any other disease simply by building a building. Whereas if you put the money in outreach clinics, prevention activities and so on, you could have had an absolutely massive impact in terms of disease prevention. I mean, if I look at my own unit, we've never achieved success through building buildings. Every major finding and publication that has come out of our unit has come out of rural clinics conducted under tents. You don't need that kind of infrastructure to be successful. What you need is what you alluded to earlier today, is human infrastructure. If you're working in a place like Uganda, if you can get access to those interesting populations with local human resource, then you're away. You've got 90% of what you need to discover things, to discover useful things.
Great. I've just got 2 more questions, and then we'll open the floor up for questions from everyone else. So to sort of touch on the topic of the conference, having worked so long and having, for example, this cohort study that you've been following, which obviously gives you a very long duration perspective of medical needs, what technologies and innovations, or are there any way you'd say this was a technology or innovation that absolutely revolutionized things and changed things brilliantly? And on the flip side, is there a technology or innovation that just made a mess of things?
That's a much harder question to answer. Before I answer that question, let me give you a bit of context. When the cohort was first developed in 1989, people were already aware that there were differences in risk of HIV disease related to wealth. Richer people tended to be at high risk. And so a great deal of thought was put into how we distinguish the richest from the poorest people in our cohort. And in the end, it was ownership of just three things that distinguished the richest quintile from the poorest quintile. And that was a plastic washing up bowl, a china cup, and a thermos flask. Those three things separate the richest from the poorest. In 2020, those same three factors allow you to distinguish between the richest and the poorest. Now, granted, there are other things we can measure now, might own a motorbike or a mobile phone, but I think it's very telling how little many things have changed. And that is reflected in adult life expectancy in the cohort, which has improved massively over the last 30 years. But because we've been measuring HIV for 30 years, we can do a stratified analysis. And if you do that, you will see that all of the improvements in life expectancy have been made in the 10% of the population who have HIV. The 90% of the population who do not have HIV have seen very little improvement in life expectancy, which I think is tragic, but perhaps unsurprising if you think where all the investment has gone over the years. Onto the technologies that have made that difference, the advent of antiretrovirals has clearly been one of the major steps forward. There have been additions of new vaccines over the years that I've been working in Uganda, notably the hepatitis B vaccine and the human papillomavirus vaccine that have made or could make major differences. We know from our own data that only 60% of children receive the hepatitis B vaccine. And the primary reason for that is that in that part of the world, 40% of women still never interact with a health facility during the antenatal or postnatal period, so their children have no exposure to an opportunity to be given a childhood vaccine. So coverage remains a huge issue. And the situation is much worse for the HPV vaccine because in Uganda, it's a school-based program vaccinating 12-year-old girls. 85% of the Ugandan population is rural, and by age 12, many girls are no longer in school. So they're missing. And then, of course, we have the COVID pandemic and lockdowns and so on. So we know that fewer than 40% of girls who would benefit from the vaccine have received even one dose, which may be enough, but it's still a very small number of girls who are getting it. So the likely impact on the population level is not as large as it should be. So the technology of the vaccine is a huge benefit. The gaps, again, come down to how we engage with the people who need it most, how we get these technologies to the people who need it most. The other thing that's made a big difference in my research point of care diagnostics. Very simple. Well, the technologies underpinning might be quite complex, but the test itself is very simple. Little spot of blood on a like a little pregnancy test thing, and you can tell whether someone's got HIV in 5 minutes. Being able to do that in the field, under a tree, with an individual sitting in front of you, and then immediately refer them to care if they need it or want it, is a huge step forward for us. When we first started the studies in '89, it took 3 weeks to get an HIV test result. And at that time, of course, because there was no treatment for HIV, nobody actually objected to being tested, but nobody wanted to know the result. There's been a complete reversal now. We can test in the field. There is something we can do about it. We can treat people. Everyone wants to know the result. So that's been a huge sea change. So I think we have seen some big successes, primarily in the area of HIV. We have more and better vaccines, but we still have failures in our ability to get those technologies to the people who need it most.
And then my last question is there this is a field in which one can achieve great things upon honesty. What would you, reflecting on your career, say are some of the things, the achievements you...
It's a field in which you can achieve novel things. Whether you achieve great things depends on whether anybody listens. And I think that is a challenge. I think Africa is neglected in more ways than just one. And, you know, we've had world leaders, notably Donald Trump, who's stated that he simply doesn't care about what happens in places like sub-Saharan Africa. And I mean, it's a sort of strange thing for me. If we learned nothing from COVID, did we not learn that international boundaries are completely meaningless in terms of global disease? You know, have a new variant of COVID in one part of the world, and three weeks later it's global. You know, diseases don't recognize international boundaries. I think to neglect one part of the world is folly, because there will be an impact everywhere. And yeah, Africa is the most diverse continent in the world. That's where humanity began. There's a huge amount we can learn from working with our brothers and sisters in Africa, and it's a rare privilege to do so.
Well, it's a great line to end on. Thank you very much, Rob. And now we have about 10 minutes for questions from the floor. I'll start with Rebecca.
Yeah, thank you so much for wonderful questions and answers. I'm super jet lagged, so I apologize if this is an idiotic question, but
well, they're the ones you fear.
Taking off from what you just said about whether anybody listens, as somebody who's also a physician and a researcher, one of the things that has occurred to me a lot working in the space of oncology is how driven oncology is particularly by good data. I wonder if it's got to do with this clinical trial culture, which permeates oncology, especially if it's everywhere. But I have often felt very deeply frustrated by the fact that where I work in Haiti, which is comparable to sub-Saharan Africa, it's impossible to generate good data. There's just sort of like necessities of uncertainty which exists everywhere, and I'm reminded of the Florence Tedeka showed in the beginning, of people writing in the margins, because that's my life. And so to enter that into a box, you either lose data or you have incomplete data, and it becomes a lot more difficult to get people to listen when you don't have good data. And so I guess I'm wondering if from your experience you can speak to that, is like how do you deal with that sort of problematic like uncertainty in data in working in these places? How do you get buy-in and legitimacy from funders or from scientists? Or is it more appropriate for us to think about how to undermine what good data even means, and to talk about like data and science, which is truly driven by the global south? Maybe there's a completely different standard, a completely different meaning of scientific certainty in places where, for example, I always like wish I could have 5-year survival rates, but I know I never will, because people move and don't have cell phone access anymore, and I'll never know if they're dead. So how do I ever tell anybody what my 5-year survival is? So I hope that wasn't too out of place.
You may be jet lagged, but that was a very challenging question. I mean, I think first of all, you're right that cancer research and oncology research in general has been blessed by a certain rigor. I'm biased. I started my career in Oxford, and I have to say I think some of that is due to the late great epidemiologist Sir Richard Doll, who really did bring a level of rigor to cancer research that's even today lacking in many other areas. And his protege Richard Peto did the same for cardiovascular disease research. So often, you know, rigor came with really smart individuals who made a big difference. Answering your question more specifically, I think working in environments like Haiti and places in sub-Saharan Africa, point number one is you cannot ever rely on routine data collection, because there isn't any. So if you want reliable data, you have to do it yourself. You have to invest and set up systems for measuring the things you need. That's a huge challenge, and it remains a huge challenge today, in no small part because funders expect those kind of data to be somehow magically available anyway. Or they think it already is. In the case of sub-Saharan Africa, they'll go to global burden of disease and say, oh, well, here are all our answers, not realizing that those data have been imputed. Imputed is a fancy statistical way of saying made up on the basis of, well, I don't know how they do it now. It's very complicated approaches and mechanisms and isn't accurate, at least for sub-Saharan Africa. So if you want mortality data, you need to set up a cohort and measure it yourself. Finding someone to fund that when they expect those data to be readily available anyway is impossible. And I've been asked that question by funders all the time, but what's your hypothesis? Well, my hypothesis is I have no idea what's going on. But that's not good enough. So it remains really challenging, and I think the fundamentals of public health, understanding what people are dying of and so on, the importance of that to underpin almost everything else you do is not well understood or widely understood, which is a tragedy, because if you go on an epidemiology course, that's what the Americans would call Epi 101. That's so basic, and yet it's not remotely well understood. Now, I'm sure if you went to a funder and said, well, I have no system for measuring survival and mortality in Haiti, and said, well, surely the government. Let's get real. Look at what we're doing. If you want that kind of information, you have to pay for it and develop it yourself. And that's incredibly hard work. Particularly in mobile populations. People moving around, you're quite right, you lose them.
Thanks for this very inspiring conversation. Yeah, my question is about you mentioned this cohort study that you did. Was it based on the study in southeast Uganda, where you actually got some database on people reporting on deaths? But it was 20% adult risk. So I just wondered if you can say a bit more about what cancers they were. Did you find that out? And also the other question I had then was many people kind of anecdotally say in East Africa haven't been writing. When I was young, people weren't dying like this. Cancer, there's a sense that cancer cases have been rising. And I was wondering, would you have found a proof of adult death being caused by cancer in HIV or some decades ago? And have you got what are your thoughts on the causes beyond the viruses, beyond infections? I'm thinking about exposure to chemicals, and also changes in diet, in the sense that people some decades ago have very gardens where they have a lot of different foods, and now it's very much like maize or like carbohydrates. So what do you have?
The first point to make is it's not my favorite. I didn't set it up, but I've been blessed to be able to use it. In terms of what the cancers are, the first thing to say is on the basis of verbal autopsy, it's actually very difficult to characterize the specific cancer types. Most of them seem to be classified very vaguely as abdominal cancer. And that could be anything. It could be gastric cancer, it could be colorectal, it could be cervical. So it's difficult to tell specifically from our own verbal autopsy data what the cancers are. But mercifully, thanks to Freddie and colleagues over many years, we've had a cancer registry in Uganda. And on the basis of that, and on the basis of simple surveys of hospital data, the picture's a bit different in Kampala, where the cancer registry is. It's a rather different population. But if you go to other centres in Uganda, cervical cancer and Kaposi sarcoma are still dominant. Cervical cancer, obviously caused by HPV, and Kaposi sarcoma caused by Kaposi sarcoma virus, but usually associated with HIV as well. And we also have a lot of liver cancer. There's a fair bit of stomach cancer in rural Uganda, less so in the capital city, so the picture's rather different. And in Kampala, you'll find increasing rates of breast cancer, for example, because in Kampala, women are beginning to take control of their own reproductive lives, having fewer children, perhaps breastfeeding for less long, the rates of breast cancer go up, as you would expect. In rural Uganda, where fertility remains very, very high, that's still relatively rare. But prostate cancer is a classic exemplar of a situation in which the best way to increase cancer incidence is to actually bother looking for it. And you can see in the Uganda registry data, prostate cancer started going up in 1986 or thereabouts. That's when the PSA test was introduced into Kampala, and people started looking. And when they look, they find it. I don't know whether it represents a genuine increase in incidence. I suspect not. I suspect it's always been there. In Kampala, there are more older people now than there used to be. The demographic profile of Uganda is still a relatively young population. Not that many people who make it into older age, and most cancers be really diseases of older age. So the incidence may be high, but if you miss it, the frequency seems to be relatively low. So I think there has always been a significant burden of cancer in Uganda. It's just unmeasured. And in recent years, we're getting better at measuring it. In the urban centres, the profile of cancers we see will be changing. For reasons we broadly understand, I think, at least in relation to breast cancer. In rural Uganda, I think the major thing that changed was the ascendancy of HIV, because that saw a massive increase in Kaposi sarcoma, which was always relatively common in men, actually. In the 1960s, it represented about 9% of the cancers in men, which would be equivalent to colorectal cancer in the UK. But with HIV, the incidence erupted, and it remains very high now. So cancer, I'm sure, has always been there. Things will change. In terms of diet, the diet in Uganda is relatively homogeneous. People tend to eat the same things every day, not a huge variety. The thing that has changed, but really only in the last 10 years, is the consumption of sugar, refined sugar, and the consumption of cheap cooking oils that have been manufactured. So studies I did with IARC, we've shown that blood levels of trans fatty acids, the short chain fatty acids that are illegal actually throughout most of the global north, has massively increased in the last decade or so. And that must be because of the widespread availability of very cheap industrially produced cooking oils, which are illegal throughout most of the world, but are widespread in sub-Saharan Africa. And sugar consumption's gone up a lot. I mean, a Coca-Cola, and you get a little bottle, has 26 grams of sugar in it. It's a big hit.
Very refreshing.
I didn't say it wasn't nice.
Especially when it's done fast. We have time for one more question. Anthony?
Yeah, thank you. Yeah, I think as you talk to you about this, some of the issues I was thinking about, even coming from the previous presentations of the variable cancers, the increase of cancer, and the types of intervention depending on type of cancer. So we are thinking about some literature already written about research about cancer ecology. And some of the concepts that I've got here in this emphasis on information. I think that like Mike and Mike's interventions set up in the map. That's what we did. And because the prosecution came into the UK, which is American continues. In this sense, I think most of the talking about what she says in the book, that the UK will not register that 9% people. So I don't know what to do about this in our national document. And as I say, like the interventions do not benefit the people. And I like the idea of improvisation by Uganda doctors then in the 1950s. Where do I actually trying to use these experiments to give the people some hope that actually we are doing something. We are using these interventions to help solve the situation. So that's really how we think about that. Because in our context, sometimes we think about such like African oncology, African charities, and then we lose the idea of oncology as a sub-program. So, for example, is the process of home and its interest because it's going to reach a larger population. When it's vital, it's going to reach a larger population. And then as pointed out, when cancer that information, I think this the very seem to be getting more to the interest of the and then as I mentioned, to what I think on top of Coca-Cola is strong brand. So I just think that I was very happy. I'm not happy. I was actually idle saying that you get very recently for some of these things. So I don't know how you can think of that. Looking at this, because Marika suggests that probably oncology should be part of the humanitarian intervention, even if it's not part of it. I
think, yeah, I've got 2 comments on that. My personal prejudice in poorer parts of sub-Saharan Africa is to focus on prevention. And the reason I say that is that at least in part of the world, cancers are diagnosed, if they're diagnosed at all, they're diagnosed very late stage disease, at a point where there's not going to be much you can do to save the individual. And maybe one should be focusing more on palliative care, which isn't done terribly well actually in many settings, and that really is a gap. So that's why I have this prejudice around prevention, because for the same dollars you can achieve so much more. I mean, let's face it, cancer it's unaffordable to treat cancer anywhere in the world in the absence of a sort of national and self-service or health insurance scheme. It's a very expensive condition to treat. So I think prevention is the way to go. There is one huge caveat to that, and that's in the area of childhood cancers, some of which, even if diagnosed at a very late stage, remain entirely curable for relatively little money. And this has been shown a number of times. We developed a treatment program for retinoblastoma in Uganda. I was studying it for other reasons many years ago, and actually looking for underlying causes. We discovered nothing of any interest, but what was so horrifying was that every single child was dying of a disease, but no child would die in the UK. And so we introduced a very simple program in neoadjuvant chemotherapy using off-patent drugs that we smuggled in from Kenya, brought in from Kenya, and used the chemotherapy before surgery to debulk the tumour, then you operate and you've got some chance of getting it out. And from almost zero survival, we now have 75% survival. And it's just a staggeringly successful, simple, holistic program. We treat kids together, so the parents bringing in a child with a monstrous facial deformity can see a child running around with a glass eye that's indistinguishable, and so they stick with the program because it's worth it to them. So there are things you can do in treatment that are staggeringly successful. In adults, we have one radiotherapy machine in Uganda. It's an aging cobalt machine that's donated by the Chinese. There's a limit to what we can achieve there. So building cancer centres and environments where you can do something. Tanzania has been a huge success, but parts of Kenya very successful. In Uganda, we've got a huge cancer centre, but it's saving many lives. So prevention is definitely the way to go. A more general comment about MCDs and our approach to MCDs is it's a mistake to assume that just because you have diabetes in the UK and you have diabetes in Uganda, that the pathophysiology of those two diseases is the same. the more we study NCDs in Uganda, the more we realise that they're not the same, and that simply importing a treatment from one place to another is, without understanding what the underlying pathogenesis of that disease is a mistake. The example of diabetes is a good one. In Uganda, many of the type 2 diabetics, type 2 in inverted commas, are not fat. They don't have insulin resistance. They're thin, and they're not producing enough insulin. It's a very, very different pathophysiology that requires different treatments. And one of the huge problems I've had over the last 14 years is in battling assumptions about the nature of NCDs in sub-Saharan Africa, and the fact that they'll all be the same as what we find in the global north. They are not. They're very different, and there's no escaping them. You have to start from the beginning and meticulously work out what you're dealing with in order to figure out what you can do about it. You can't escape from the need to invest properly and to do proper, robust, thorough work. I get so tired. Every funding application you see, they're looking for novelty and innovation. I long for the day when a funder says, no, forget that. We just want meticulous, thorough work that's going to give us an answer that we can use.
Great. Well, now we just need to collectively find the people who are going to fund meticulous epidemiological work. Thank you very, very much, Rob, for this fascinating walk through 30 years of work in East Africa. It was really great. Thank you.